Describe what you see in this video.
Yes, I can see an infant, a toddler. He is well alert and well grown for his age and irritable, crying because of maybe because of pain, and he's having in the picture he's shown behind the left ear. It's there is redness, erythema, swelling, so more and shiny skin, most likely suggestive of mastoiditis, left ear mastoiditis, and a picture is showing having connected to the uh, oxygen saturation monitor. So yes, yeah, so on the monitor he's having 141 breaths beats per minute heart rate, and oxygen saturation is 97%, and BP is 81 by 44. So by compiling all this, my provisional diagnosis is
Temperature
this is
chart
the
also showing now. High grade temperature.
I couldn't get it, doctor.
Okay.
No.
So what is your diagnosis and what is your DD?
Yes, my diagnosis is acute mastoiditis.
Any keeping DD? Differential diagnosis?
Yes,
Okay.
for mastoiditis, any ear trauma, any head trauma, any cellulitis, bone cyst or tumor, parotid swellings, cervical lymphadenopathy, meningitis. Yeah.
Okay. Okay. Nice. So I can see a toddler who is average for age. The toddler is on hospital setting. He is irritable. He's crying. There is monitor attached, and there is the important finding. I see that there is a swelling behind the ear. It is redness around and pointing. It is shiny and discharge not visible here. But it what happened? It pushing the ear downwards. So it is a case of acute mastoiditis on top my diagnosis, and the differential diagnosis I am keeping like any non-accidental injury, lymph node abscess, cellulitis, any head trauma, otitis media or externa, bone cyst or tumor, parotid swelling, and meningitis. And what are the organism responsible for acute mastoiditis?
Yes, it's a Streptococcus pneumoniae, Streptococcus pyogenes, and
Yes,
Staph aureus and Haemophilus influenza.
right, right. So, acute mastoiditis, the organism responsible are Streptococcus pneumonia, Streptococcus pyogenes, Staphylococcus aureus, and Haemophilus influenza. What history we ask?
Yes, I would like to ask about the onset course duration. When did she notice it first, and is it the first time or recurrent, or any pain behind the ear, and any history of discharge, fever, any weight loss, any other lymphadenopathy? How is it affecting his sleep? And what about the history of feeding? And what about any other trauma, vomiting in the morning, any
Yes,
hearing infection,
yes,
any
yes. So, the history we are keeping the diagnosis in our mind and the DT. So, first onset course and duration, what increase and what decrease. Is it first time occur or recurrent occur? Then fever, irritability, weight affect his activity. So, FWSL, fever, weight, activity, sleep. Then ear, any discharge from the ear and its color, previous history of any ear infection or hearing loss, headache, especially morning vomiting, change in behavior, neck stiffness or fits. So brain tumor features they are choosing that morning vomiting, change in behavior, personality, neck stiffness for meningitis. We are keeping differential diagnosis. Ask about the family dynamics and family registered to social worker because NAI we are keeping. So what examination we do?
Yes, I would like to do the complete head-to-toe examination of the patient. I would like to check for the air patency of the airway, breathing, and perfusion. Also, I would like to check for the vitals, especially the BP, and any signs of fractures all over the body, any affection of the hearing, complete hearing ENT examination, and to look for the tympanic membrane as well. Is it bulging? Any cranial nerve affection? Cranial nerve 6, 7 palsy, any fifth cranial nerve palsy? And is it a fluctuant examination of the swelling itself, the size, surface? Um,
Okay.
yeah.
So first, as usual, airway breathing circulations, vitals, hydration status, take the measure and plot on appropriate centile. Then it is a swelling. So examine the swelling itself for signs of inflammations, fluctuated or not, redness around and discharge. So if rash, we tell the rash history. It is swelling, so swelling, it is fluctuated or not, it is tender or not, any discharge present or not, it is surrounding, it is size, like that. It is temperature, it is any hot or cold, we can see that. Then ENT examination, ER related ENT examinations, full ENT examination we are doing. We are doing hearing assessment, lymph node examinations, and full neurology examination, cranial nerve examinations. Because full neurology is there is it can be deteriorated the CNS functions. Okay, what investigation we do?
Yes, for a full blood count, anti-inflammatory markers, ESR, CRP, and other lab investigations, I would like to send for the blood culture and radiological investigations, including skull X-ray, head X-ray, and CT or MRI to look for any pathology or any focal neurological, if there is any focal neurological signs, and LP if there is suspicion of fever and neurological signs as well. And
Yes.
audiogram
So if it is
during
a
or
case of
after
inflammatory
colonoscopy.
case, we are seeing that the child is high temperatures because signs of infections we are seeing, abscess C. So full blood count, yes, CRP anti-inflammatory marker we are telling the common. Then ENT related, keep in our mind, hearing assessment, hearing test, radiology, CT or MRI, because neurological sign we want to see the NAI, LP if meningitis, SDD we keeping. And what is the complication of this case?
Yeah, they can get conductive hearing loss and any abscess and intracranial spread like meningitis and cerebral abscess can occur, and sinus thrombosis, venous sinus thrombosis, and cranial nerve palsies.
Yes. So we are ER and CNS. We are dividing two headline. ER is labyrinthitis, otitis externa, osteomyelitis, hearing loss, subpedestal abscess. Then meningitis, cavernous sinus thrombosis, brain abscess, facial palsy. So first hearing loss as it is related ER. It surround the brain, meningitis, cavernous sinus thrombosis, facial nerve palsy, then abscess formations. These are we keep labyrinthitis, otitis infections. How can you manage this patient?
Yes, these patients need admission. We will start analgesia, uh, antipyretics, and antibiotics. Antibiotics include ceftriaxone and clindamycin for 2 weeks, and coamoxicillin once improving. If not responding, then in drain tube middle ear, and if no response, then surgical intervention, including yeah.
Okay. So that is management. I admit the child must analgesia antibiotic. I am giving antibiotic. I am giving ceftriaxone, clindamycin, IV. IV ceftriaxone, clindamycin. That is after 48 hours. If it is improved, change to oral coimoxiclav. Total duration of treatment is 3 weeks according to ENT opinion. Then surgical drainage, mastoidectomy, tympanoplasty, myringotectomy. So surgical drainage we tell. Antibiotic, remember pneumonia, pleural effusions. Then we are going if orbital cellulitis, periorbital cellulitis, and that is acute mastoiditis, everything. We are starting with IV ceftriaxones, and when improve, we are going coamoxiclav. Okay. Then what
Okay.
advice you are giving, and some red flags? Tell me.
Red flags if he is having any abnormal movements, any change in the behavior of the child, any
These are red flags.
fever.
Advice is another thing. I'm telling you.
Advice
Advice we are giving wearing earplugs during swimming or shower. Analgesia, place the warm compression on the ear and shower after 1 week. Stay out of the school 7 to 10 days. So she will be use the earplug. Avoid swimming for like 7 days. Avoid school. Analgesia use and put hot compression. And sign of intracranial sign of red flags are increased intracranial pressures, facial pain or deviation, persistent fever, like it's not improving, hearing problems and vision problem. So these are the red flag sign of increase intracranial pressures, hearing problem, vision problem, facial deviations, condition is improving. And the multidisciplinary team, what we include in this case?
ENT and
Yes. First, my consultant pediatrician and ENT we are involving. And if surgery needed, so anesthesia we can keep, right?
okay,
And
yes.
support to the family, psychological support to the family. They are upset. This also we can keep like that. If needed, lies with the school. If needed, that. Otherwise, okay. So this is all about this video station. Thank you.
Thank you so